my honor to welcome Dr. Abecassis, who's from the University of Louisville, to speak about estimating the risk of aneurysm bleeding and strategies for treatment. We all know this is a scary subject. I'm sure many of you have been through it, a loved one has been through it, you may have lost somebody. So we're just really excited to have Dr. Abecassis here to take the time and share with us his knowledge on the subject. So with that being said, I'm going to toss it over to you, Doctor.
Thanks, Christine. Thanks for having me. Thanks everyone for tuning in. It's such a privilege to be here. My name is Josh Abecassis, and I'm at the University of Louisville in Louisville, Kentucky. And I'm going to talk today about estimating the risk of aneurysm bleeding and some strategies for treatment. A bunch of logos on the screen. We have a Brain Spine Institute at University of Louisville. We have a bypass program that I started about a year and a half ago. I do some consulting for a lot of the companies that make devices and catheters, and I will talk a little bit about them. I'll kind of let you know when I do. We have grant support, and then we have a couple of clinical trials, including an aneurysm device trial, Seal It, that I won't really discuss, but when we go over treatment options, I'll briefly kind of allude to it. So here's a brief outline. We're going to first talk about how do we compute the natural history of intracranial aneurysms? What are the papers? How do we come up with the risk of rupture? I'll do an example of a patient-specific calculation, kind of exactly like I do it in the clinic. I'll talk a little bit about future research and things that I think are really exciting in this domain of estimating risk of rupture. And then we'll end with some treatment options and examples before conclusions. So, how do we counsel on natural history? So, natural history meaning if you're diagnosed with something and we don't do anything about it, what is the natural history? So, obviously, I think it kind of starts with understanding the diagnosis, beyond just having a brain aneurysm. Where is it located? I think this group knows, you can really get them anywhere along the intracranial vessels. Some locations are more common than others. So, obviously we have two internal carotid arteries that come up and go into the head. And then we have two vertebral arteries in the back of the neck that come up and form the basal artery. And this kind of forms a circle, or the circle of Willis. And so aneurysms can be at the bifurcation, where blood flow is kind of hitting the wall of the blood vessel that it, otherwise would go into one vessel or the other. Or they can be sidewall aneurysms, like posterior communicating artery aneurysms. The most common site that we see are anterior communicating artery aneurysms, so kind of right between your two eyes, not on the right or left side, but kind of in the middle. We call that the ACOM. And that's also, unfortunately, the most common site that we see ruptured aneurysm. So that aneurysm has a very different natural history than, say, an aneurysm at the MCA bifurcation. I'll show a little bit of numbers behind that. This is the first study that I like to show because I think it's one of the first ones that was published. It's called the ISUIA, so International Study of Unruptured Intracranial Aneurysms, and it was involving patients in Europe, in the U.S., across the world, and essentially what they boiled down was that the two most important things that predict what the risk of an aneurysm bleeding are location and the size. So larger aneurysms have a higher chance of bursting, and certain locations seem riskier than others. So um, if we look at the first column, you see location. So, group one aneurysms, by the way, were patients that had no history of a prior bleed. Group two patients did have a history, so prior subarachnoid hemorrhage. So that's the other thing that it showed. And these are 5-year rates. So these are not per year. You have to divide them by 5. So the first really interesting thing that this showed was that cavernous carotid aneurysms, which we know, if we look back, these are aneurysms that are in the cavernous sinus. They're not even on here. They're not in the subarachnoid space. They can't cause intracranial hemorrhage if they wanted to. Even the fact that they can't cause intracranial hemorrhage, they could cause a CC fistula. The risk of them bleeding is very, very low. I mean, it was zero even when they were pretty big, like a 1 centimeter or 10 millimeter cavernous aneurysm. And even when they're giant at 25 millimeters or larger, the risk of them bleeding is 6.4% over 5 years. So less than 2% per year. If you look in contrast, a 25 millimeter aneurysm that's, say, a PCOM aneurysm or a posterior circulation has a 50% risk of bleeding. And that's causing a brain bleed, not a CC fistula. So the first really important takeaway from this is that if you have an aneurysm that's in the cavernous carotid artery. That is, it's first of all, it's not in the brain, but even if you're worried about it causing a fistula by bleeding, the risk of it bleeding is very, very low. The second thing that was interesting is that they grouped aneurysms into anterior circulation, so anterior meaning the front, and posterior circulations. And if we look back again at this, at this picture, posterior communicating is actually a lot of people consider that to be anterior circulation because it's coming off the carotid artery. So it's just something interesting to note. They grouped PCOMs with the posterior circulation. What they found was that posterior circulation aneurysms had much higher risks of rupture than anterior circulation. So, for example, if you look at posterior PCOM, group one, no history of subarachnoid hemorrhage, less than 7 millimeters. The aneurysm had a 2.5% over 5-year risk. So that's about 0.5% per year. And that's kind of high. What does that mean? How do you take an annual percentage and compute lifetime risk of rupture? Well, it's kind of a complicated equation. That equation is listed below. It's 1 minus and then 1 minus the risk of rupture to the power of the life expectancy. So let's say, and it depends on how long you're going to live. Let's say you know you're going to live till you're 80, which we don't ever know that, right? We don't know when we're going to live. I tell my patients, I hope you live to 100, but let's assume for the sake of argument, you live to like 85. If you're going to live 20 years, and you have a 5 millimeter PCOM aneurysm, so your risk of rupture is 0.5%, well, then your lifetime risk of rupture is 9.5%. The other way to do that is to say, well, a 0.5% times 20 is about 10% lifetime. It's not perfect. The curve ends up being a little bit less than that equation, but if you want to guesstimate it, I say just multiply the risk of rupture by the number of years you have for life expectancy. So that's the ISUIA. Now, there are a lot of criticisms of this study. The biggest criticism is that the most common ruptured aneurysm that all of us see, we know, is like a 3 millimeter ACOM aneurysm. That's just across the board. If you talk to people that treat ruptured aneurysms, and if you look at ACOMs, which were included in the whole lump sum of anterior circulation. So where it says AC, MC, IC, they put ACOMs in that category. Somehow the risk of an aneurysm bleeding that was less than 7 millimeters was zero. Now, is that right? We know it's not because we see so many ruptured ACOMs that come in at about 3 millimeters. We also know that aneurysms do not shrink when they burst, right? When they come in at a 3 millimeter and they have a subarachnoid hemorrhage, people have gone back and looked at the patients that we had pre-rupture baseline imaging on. And it turns out when an aneurysm pops, it does not shrink down. So something didn't add up about the ISUIA, but it's a really, really important study. And a lot of people still rely on it heavily to estimate natural risk of rupture. Again, a lot of this has to do with the life expectancy. And this is something that's hard to pin down in the clinic. One thing I do is I ask patients, how old were your parents when they passed away? What did they pass away from? You'd be surprised. Some people are like, well, my mom lived to 99 and my dad, 110 or something. So the life expectancy in general is lower in the US than some other countries. If you look at by gender, you can see that females tend to live longer than males. In addition, there's a lot of race disparity. So some ethnicities, Asian, tend to live longer than, say, African American or Caucasian. The next study I want to talk about that I really like is called UCAS. It's the unruptured cerebral aneurysm study, and it's really out of patients from Japan. This was a lot of aneurysms, so over 6,000. And what I like about this study is that they broke down location, if you look at the first column, really to a granular level. Excuse me for 1 second. They looked at a lot of different locations, including ACOMs separately. They looked at MCA. They looked at PCOM separately. Really a ton of different locations. And what they found is the size really does matter. So if you look at ACOMs, for example, that were 3 to 4 millimeters, the risk of rupture was almost 1%, 0.9%. So that was a big difference than what the other study showed, the ISUIA. If you look at posterior circulation like basilar tip aneurysms, they weren't as bad as you would think based on ISUIA. The risk of a 3 millimeter rupture was only 0.2% per year. I really like this study because it doesn't say, let's group all aneurysms that are less than 7 millimeters into one category. It breaks it down. So 3 to 4 millimeters, 5 to 6 millimeters, 7 to 9 millimeters. And then it goes into aneurysms that are a little bit larger, like 10 to 24 millimeters. So again, if 0.5% is kind of a high risk of rupture, ACOMs that are 3 to 4 millimeters all of a sudden are not that benign. And so that was a huge takeaway from this study. Same thing with PCOMs. An annual risk of rupture of 0.41 is not insignificant, but it doesn't capture every location, right? So I think this breakdown of location is better than the ISUIA, but it's still not perfect. What about aneurysms like this one? So this was a patient that came in with subarachnoid hemorrhage. You can see a CTA on the left. And I'll play a video that kind of shows it's this little blister. You can see it there. That's a P1 aneurysm. We don't know what the annual risk of rupture is for P1 aneurysms. They're just not captured in natural history. So this was one that I treated with Comaneci assisted coiling, and you can see, the red circle, the aneurysm. You can see the coil mass. That's the Comaneci device. It's basically a temporary stent. And so you inflate it. It doesn't arrest flow. It kind of scaffolds the coil mass into the aneurysm, and then you take it out. So you don't leave any stent, which is you don't want to use stents ideally in a ruptured case because you have to put patients on dual antiplatelet therapy. And those are some other views, next to it. And about a week later, I saw the exact same aneurysm pop up, different patient, same location. So, you got to ask yourself, like, what does that mean? If I see two patients that have ruptured P1 aneurysms, what do you tell patients that come in that, have an incidental unruptured P1 aneurysm? Is the risk of it bleeding, 100%? No. And so I think that's a big takeaway too, is that those two studies I showed you, UCAS and the ISUIA, are very different than a study like this, which looks back at a series of PCA aneurysms, including P1 aneurysms, and says, well, when we look back at all the aneurysms we saw here at, University of wherever, we saw 50 of them and 25 of them were ruptured. Does that mean the risk of rupture is 50%? No. That's a very different type of analysis than a natural history study. So what UCAS and ISUIA did was they found patients that they were unruptured and they actually followed them. They didn't, predict what it would be. They literally followed them until they ruptured, if they did, and then they figured out the risk of rupturing. So just because an aneurysm presents with a hemorrhage does not mean that it's a super high natural history risk. There's a couple of other ways that you can estimate risk of rupture in addition to just looking at UCAS or ISUIA. And one of them is called phases. So phases is a score that you compute, and it takes into account a couple of different things. It's based on a lot of these natural history studies. So these are the ones that they include. And you can see the top one is ISUIA and the bottom one is UCAS. And there are a couple other studies even that they included. You can see UCAS had the highest number of patients, 5,000, over 5,000 patients included. And the second biggest one was ISUIA. Very different time periods. So 91 to 98 versus 01 to 04. That's important to pay attention to. And obviously, UCAS is only Japanese patients. And Japanese patients, we know, have a higher risk of rupture. So you do have to take the numbers that come out of UCAS with a grain of salt if you're not Japanese. Phases stands for population, hypertension, age, size of the aneurysm, earlier subarachnoid hemorrhage from another aneurysm, and site. And so those are if you look at the breakdown, again, population. So if you're Japanese or Finnish, you get more points. You're at higher risk of rupture. If you have a history of high blood pressure, it doesn't matter if it's treated. If you have a history of it, you get a point for increasing, the chance of it bleeding. Age. The age is an interesting one. So if you're 25 years old and you have an aneurysm, the chance of it bleeding over your lifetime is higher than if you're 70 because you don't have as many years of life. However, I always tell patients aneurysms are like hernias of the blood vessel. It's basically a weakening, same way you get a hernia in your abdominal wall, it's a weakening in the wall of the blood vessel. So the older you get, the more the chances that the artery wall has kind of thinned out. So actually, older age is a risk factor for rupture. It predicts rupture more than being younger. Obviously, larger aneurysms, are riskier. If you've had a prior bleed, that's riskier. And then location. So again, look, they put ACOMs, anything in the anterior cerebral artery, PCOMs, and posterior circulation, all in the highest risk category, which gave 4 points. You add up all the points that you get, and you look over on this side, and then that gives you, again, a 5-year risk of rupture. So if your total phases score is 9, your 5-year risk of rupture is 4.3%, which is pretty low. That's, less than 1% per year. But that's phases. So it gives you a score. And people have shown that phases works. People have looked at patients that have unruptured aneurysms. They've looked at, which aneurysms go on to grow and which stay stable. And they've been able to show that if you have higher phases score, you're at risk of this aneurysm potentially growing. So it's not just bleeding, it can be unstable. This is another prediction score called ELAPS, ELAPSS. And again, it was based on, this isn't like a study like UCAS or ISUIA that actually follows patients with aneurysm. It looks at existing studies that did that. And so, again, what does ELAPS stand for? So, earlier subarachnoid hemorrhage, location of the aneurysm. Again, interestingly, in this one, I don't know why, ACOM is a low risk location. It gives 0 points. Whereas PCOM in posterior circulation gives you 5 points. So that's very similar to ISUIA, but not similar to, I would say, a real world experience or to UCAS. Again, age here, they use 60 instead of 70. Again, population, Japanese and Finnish, higher risk of rupture. And then size, larger aneurysms. This one also uses, is the aneurysm regular or is it irregular? What does irregular mean? Well, that means instead of being a smooth, round, saccular aneurysm, you might have a little bleb or a teat or some sort of daughter sac. Those would be the terms that you would hear. And again, you add up all the points, you get some sort of a risk score, and then this gives you a 3-year and a 5-year risk of rupture. It's not just multiplying an annual risk of rupture by 3 and then 5. It's actually saying, well, at 3 years it's this, and at 5 years it's this. In addition, so we've talked about ISUIA and UCAS. Those are natural history studies that give you a precise number. We've talked about now different scores like phases and ELAPS. Those are not natural history studies, but it takes in a lot of information and spits out an annual risk of rupture. Well, there's another tool that I think is really useful called the unruptured intracranial aneurysm treatment score. And I put the list of the authors, including Dr. Ogilvy, on the left because it's a bunch of worldwide experts, neurosurgeons, radiologists, neurologists, all people that are considered experts in the field, and basically got them together and they came up with this calculation. And they said, on one side, we're going to add up all the points that say we should treat the aneurysm. On the next column, we're going to add up all the points that say we shouldn't treat the aneurysm. We're going to do A minus B, and if that number is positive, it means you should treat. If it's negative, you shouldn't treat. If it's between -2 to 2, it's sort of in a gray zone. This doesn't mean like you can't treat a patient that has a score that says you shouldn't treat it, but it's a really useful tool, right? So if you look at the things that say that they should treat aneurysms, again, even though older patients have a higher risk of rupture, this treatment score argues that the younger you are, the more likely you should treat it, which I think makes sense. If you're 40 or 35 years old, you've got a lot of life ahead of you. The risk of that thing bleeding or causing problems is higher. Other risk factors, these are all things that this group thought, increase the risk of rupture, and I agree. So previous subarachnoid hemorrhage, a family history, Japanese, Finnish, or Eskimo, Inuit ethnicity, current cigarette smoking, high blood pressure, autosomal polycystic kidney disease. So that's a genetic disorder that the blood vessels are not healthy. Current drug abuse, mostly cocaine and amphetamines. Those are the drugs that we know lead to aneurysm formation and can lead to rupture. And then current alcohol abuse, that's also included. Are patients symptomatic? That's rare, but is the aneurysm so big it's irritating the temporal lobe and you have epilepsy? Is it so big that it's flicking off clot that's causing stroke? Is it so big it's compressing a cranial nerve? Well, we see that sometimes with PCOMs. PCOM aneurysms can indent the third nerve. Does the patient have a reduced quality of life due to fear of rupture? I like that that's accounted for here. We don't really see that in some of the annual risks of rupture. That's important. And then, larger, is it irregular? What's the location? Again, they're giving points for ACOMs and PCOMs, for basilar, and then anything in the posterior circulation. Has it grown? Have you followed it, and is it growing? What are the things that argue against treatment? Well, life expectancy. If it's less than 5 years, you're going to lose points, that argue we shouldn't do this. Do you have medical comorbidity? Psychiatric disease is big, neurocognitive disorders, et cetera. And then age. So again, if you're greater than 80, you're going to get a lot of points saying we shouldn't do this because that's risky, putting a patient to sleep, whether it's endovascular or open. And then larger aneurysms, even though you get points for saying, well, this is riskier, well, guess what? Treating an aneurysm that's giant, that's risky. That's riskier than treating a 1 millimeter aneurysm. So you get points against that. So you add it up. So I like this treatment score because it's different than our natural history stuff. Um, and this is the Hopkins group. They looked at UIATS, phases, elapse, how do they all compare to what we actually do in practice? And the answer is some do better than others. UIATS and elapse did really well, at least compared to the way that people at Hopkins practice medicine. Doesn't mean that it's the way that everyone has to do it, but it's a very strong institution that sees a lot of aneurysms. So it's a good surrogate for other academic centers. And you'll see that phases, again, I was telling you, those risks of rupture are very similar to ISUIA. They're very low. You see that it's not compared well to the optimal model that they had, whereas ELAPSE and UIATS were. So let's do an example. This is a patient, this is a 58-year-old male, has a history of hypertension, active methamphetamine use, tobacco, and this is found incidentally. He was admitted for headache, he had a CTA, and then I did an angiogram. And ignore the clips on look at the first angiogram, which shows the aneurysm. You can see this is an ugly aneurysm. It's an ACOM location. It's got multiple little blebs, and so it looks very irregular. So what is the risk of this patient having a bleed based on all of the things we just talked about? So if you look at UCAS, it's 1.97% per year. So again, we said 0.5% per year was high. If you look at ISUIA, which again is fairly low, you see that it's 0.5% per year. That's still a pretty high annual risk of rupture for someone young. If you look at phases, it comes out to 0.6% per year, and then elapse either is 5.8% per year or 3.6% per year, depending on if you use a 3 or a 5 year. So if you take all these numbers, and this is what I do in clinic, I say the risk of your aneurysm bleeding is anywhere from 0.5 to 5.8% per year. I don't know where it is within that thing. If it were me, I would assume it's the higher risk of rupture because you don't want to assume it's the lower and then you have a rupture. Like, well, I thought it was this number, right? Um, if you look at his life expectancy, what is the life expectancy of a 58-year-old who's using methamphetamine? I don't know. Is it 10 years? I mean, he could overdose tomorrow. Um, let's assume conservatively it's 10 years, then his lifetime risk of rupture would be 18%. If we do the UIATS treatment score, it comes out 19 points saying we should treat, 10 points saying you shouldn't. The difference is +9. That suggests that we should treat it. So that's what we did. And so you can see again, if you look at the video, you can see 3 different clips kind of reconstructing this aneurysm. And so that's kind of an example of how I do it. Here are some pictures from the operating room. So you can see the aneurysm blebs. Here are the 3 clips going on, closing down the aneurysm, keeping the A1, the recurrent artery of Hubner, and the A2 open. And here's the angiogram, showing the right and left internal carotid artery on the bottom, that the open with no issues with flow to the brain. You can see the X-ray of the clips. So that's a little bit about natural history. That's a little bit about what tools we use to give patients not only a number, but just a sentiment. Is this something we should treat? What's on the horizon, as far as predicting risk of rupture? I think there are really 3 different things that are on the horizon. So the first is vessel wall imaging. What's vessel wall imaging? This is not something that's done, as you can see, in any of the treatment scores. It's not factored in. So this is an MRI, and basically you give contrast, and you don't look at the brain, you don't look at the blood vessels, you look at the wall of the blood vessel. And so if you look at the picture here, this is an angiogram showing a very large and irregular PCOM aneurysm. These are all unruptured. And you can see before contrast, nothing lights up. After contrast, you can see that it lights up. So there's wall enhancement in the aneurysm. Well, what does that mean? The reason it's not quite mainstream yet, meaning we don't do this routinely at every center and it's not factored into, what's the risk of my aneurysm bleeding, is We don't know if an aneurysm, the wall of the aneurysm lighting up, necessarily means that it's unstable. We think that it does. So it probably means there's some inflammation, but it could mean that there's something else going on there that's causing, it all it means is contrast is going into the wall of the aneurysm. Again, I would think, and I think a lot of people think that that means it's unstable and that it's got inflammation. If you look in contrast to the one that I'm just showing you in the bottom picture, it's an MCA, which we know has a lower risk of rupture based on everything. And it's smaller. It's not doesn't look to be as unstable. And interestingly, there's no enhancement of that wall. So what this group did, and now if you turn your attention towards the bar graphs, they basically said, we're going to look at aneurysms that have wall enhancement and ones that don't. And the first picture you see in A is what they found is that larger aneurysms all had more enhancement than smaller aneurysms. Well, we know larger aneurysms are more risk at bleeding. Then they showed aneurysms that are in risky locations, ACOM, PCOM, ACA, versus low risk location, like an ICA, a non-PCOM ICA, so an ophthalmic, a superior hypophyseal. The higher risk locations had more wall enhancement. Finally, on the bottom, they show that what if we do a phases calculation? So again, let's bring it all back. Let's look at what does phases say about. So now they're talking about the age, the population, the hypertension. The MRI with contrast has no idea that the patient is Finnish or Japanese. I mean, it's totally blind to that. Yet patients with higher phases score showed higher rates of aneurysm enhancement. So I think this is definitely something that in the next 10, 20 years is going to be part of routine triage of unruptured intracranial aneurysms. So I do think that enhancement of the wall is a good surrogate for instability. The second thing that is on the horizon, and this is what my lab does here at University of Louisville, is computational fluid dynamics. So what is that? CFD. Computational fluid dynamics is basically taking a CT scan or an angiogram of a patient's aneurysm, simulating on the computer blood flow. So pretending like, it's not in real life. It's basically a simulation. And it doesn't factor in what the patient's actual blood pressure is. It doesn't factor in how stiff the aneurysm is or whether there's a little bleb. But it's kind of a theoretical simulation of blood flow in the patient's actual anatomy. And it gives you really nice pictures like this. So this is from Juan C. Bral's group, who's a world expert in CFD, and we're actually working with him on a collaboration right now. And what you see is in the top panel, you see a CFD analysis of a MCA aneurysm, and on the bottom, you see a CFD analysis of an ACOM aneurysm. And basically, you see much more turbulent flow in higher risk locations. And you see all these crazy vortices. Whereas in a more benign location like an MCA, you don't see that as much. Again, what does this mean? We don't have a good way to translate CFD to a risk of rupture yet, at least in a reproducible way. But we're working on it. And this is something we're working on specifically at U of L. We just did an analysis today on a patient with a really large, nasty ACOM aneurysm that's getting treatment. Finally, I think artificial intelligence is very much on the horizon. What's artificial intelligence? Well, it's basically machine learning. It's taking a lot of data. So thousands, hundreds of thousands of aneurysms. It's plugging it all to a computer. It's saying, well, this one grew, this one was stable, this one grew. And a machine says, I'm picking up that this one, the ones that all grew had this feature, and the ones that didn't grow had this feature. So I think we're in an era of a lot of data. We're getting better at sharing data. We're getting better at putting this all in the cloud in a protected way and collaborating with people across the world. So there's no question that AI is going to be part of the future. And it's probably going to include a lot of things, not just the angiogram, but vessel wall imaging. It might have a blood test that looks for certain genes that are associated. It might, take into account age, whether there's smoking, whether there's a family history, and it's going to plug it all into some sort of program, and it's going to spit out a prediction, that this patient's lifespan is going to be to here. We predict it'll rupture here. You should treat it because of this. So now shifting gears kind of to the last thing that we'll talk about, and I guess we're doing well. We're running ahead of schedule, which is always better than behind, is what are the options? And I think the classic debate is clipping versus coiling. And I don't like that. I think, those are tools in the armamentarium. You see microsurgical clipping in the bottom left. You see simple primary endovascular coiling, but really we do so much more now. So there's microsurgical options, meaning an open craniotomy with clips of some sort. There's endovascular, which really does not just mean um, coiling exclusively now, um, or both, some sort of a hybrid approach. So these are the endovascular options, and it's going from simple to complex. So on the far left, you can see coiling. This is an ACOM aneurysm. So in this, we get access from the wrist or groin artery, and we use little wires and catheters, and we basically wire into the aneurysm with a microcatheter, and you put out platinum coils, and that occludes the aneurysm. The problem with coiling is durability. When we look at endovascular results and compare it to surgical, over time with high blood pressure and everything, the coil mass tends to compact. That doesn't mean it does in every case. It's an excellent solution for a lot of aneurysms, but that's kind of the problem that we see with endovascular coiling. Um, what about Coiling Plus? I put Coiling Plus because there's a lot of different devices you can use. So the first picture you see is a balloon. You can use a balloon. And what that does is it gives you something to bounce your coils off. So particularly if the neck of the aneurysm is too wide, the coils may not want to stay in the aneurysm. If you look at the picture of primary coiling, it's a very narrow neck. So there's barely enough room to get the microcatheter in. So of course the coils are going to stay in that. Well, more often than not, you have a wide neck. And so you go in with your microcatheter, coils are going to want to come out. Well, if coils come out, they're going to go into the blood vessel that's going to the brain and you can have a stroke. So you may need some sort of a device like a balloon. The problem with a balloon, obviously, is you can burst the blood vessel, you can tear the neck of the aneurysm, and you can have a stroke because when the balloon's inflated, you may not get blood flow to the brain. But it's a great device that we use a ton. If the aneurysm is unruptured, you can use a stent, a permanent metal stent that you get your coiling catheter in the aneurysm. Alongside it, you deploy a metal stent that buttresses the coils that are in there and probably helps the aneurysm heal from the inside out to some extent. So that would be called stent-assisted coiling. The only issue with stent-assisted coiling is you need to go onto two strong blood thinners if you're going to put a stent into the body. And if you come in with a ruptured aneurysm, it's not great to use blood thinners if you can avoid it, because you may still need a shunt for hydrocephalus. You may need other procedures down the road. On the bottom of that picture, you see another picture of stent with coils. And then the other picture that you see on the bottom left is a Comaneci device. So that's a temporary stent. And so that you put into position, you have a little clicker on the back of the table. As you click it, it kind of fluffs the stent open. The nice thing about that device is, number one, it does not rupture the blood vessel ever that you're in. Number two, you don't get any arrest of blood flow like you do with the balloon, so blood can still go through it. And number three, you can take it down and take it out, so you don't have to leave a permanent stent in. So Coiling Plus is balloon-assisted coiling, stent-assisted coiling, or Comaneci-assisted coiling, pretty much. The next treatment that came along was flow diversion. So flow diverting stents totally revolutionized, the game in aneurysms, particularly for certain locations. So what you see here is an ophthalmic aneurysm or a paraclinoid location. These, historically we could treat with coiling or with clipping. Coiling tends to have recurrence. Clipping is it's a long surgery. It's a lot of drilling. You're in the operating room for 6, 7 hours. This is a 45-minute case and it has really good results. That's the important thing. Flow diversion in the properly selected aneurysm has over a 90-95% risk of curing the aneurysm. And so sometimes you use coils with the flow diverting stent, if the aneurysm is big enough. And finally, moving over to the far right, I think this is the newest generation of endovascular devices. The one shown there is Webb, or woven endobridge device, which is the only FDA-approved intrasaccular device right now. But there are a number of other devices that are currently in testing. We're at University of Louisville participating in one with Seal It, but there's a bunch, Artis, and the idea with these is they just plug the aneurysm. So instead of having to put out, 5, 6, 7 coils, you go into the aneurysm, you deploy this kind of, um, this shaped device. It doesn't matter if it fills up the whole aneurysm. The important thing is that it seals the neck. So it has to plug the neck of the aneurysm. And we don't know how this is going to do long term. We're just now starting to look at 5, 10-year results from the trial in the US. And, it's a very soft and safe device. which is great on deployment and it looks really good. Unfortunately, sometimes that means it will compact and the aneurysm can recur at the neck over time. And, I think I just treated an aneurysm with surgical clipping of one of these devices that had recurred. So it's not definitely the best solution. These are all options that we have in the armamentarium, and the idea is find the best solution. What about microsurgical reconstruction? Again, we say clipping, but it's really more. This is from Dr. Mike Lawton's book, Seven Aneurysms, which is really good for anyone who's treating aneurysms on the call. And what it shows is simple clipping, which is in the upper left, is really only one thing that you can do with clips. The reason microsurgical clipping is such a nice treatment option is it gives you incredible precision. Rather than relying on a device that's shaped a certain way and you're in the wrist or the groin and you're kind of pushing and you don't know where the device is going to go, you kind of try to inflate a balloon to put it in. Well, with surgery, you've got it all right in front of you. If you want to clip here, you put it there. If you want to clip there, you put it there. If you want to back one off a little bit, no problem. So you can see there's simple clipping. You can do fenestration tubes. So these are clips that have a hole in them and you can reconstruct the artery from a reverse. I really like the far right, the dome tube. I call that a picket fence. You've got this big aneurysm and what I like about that is these aneurysms often have a lot of plaque. They're really ugly, they're big. And so the problem is if you only had one clip on, you might pinch off the blood vessel and cause a stroke. But when you have 4 or 5 clips on, you can look at it, you can Doppler it, you can do an intraoperative angiogram. And if something looks a little too tight, you can back that clip up by a millimeter and it will look almost perfect. So I think the beauty of microsurgical clipping is it's not clipping, it's really a reconstruction of the vessel. It's nice when you can do it with simple clipping, but that's really just one thing. And then finally, within microsurgical, there's not just clipping, but sometimes you need to do a bypass. So here's on the left is a picture of a case that was published by one group, and it shows, the aneurysm. Again, look how yellow it is. It's really hard and calcified, and that we tend to see with really large and giant aneurysms. There's not a good way to coil that off. And if you look at the schematic picture, it's not like an aneurysm that has a neck. It's a blowout of the main MCA vessel. You can't put coils in that. You can't clip the aneurysm only. The whole vessel is diseased. When the whole vessel is diseased, you either need to use a flow diverting stent or you need to do a bypass, one of the two things. And so what they've done here is you see a clip. It's not on the aneurysm, it's on the vessel going in, going into the aneurysm. And then you see a bypass. In this case, it's a radial artery, which comes from the arm. But you can also use saphenous vein in the leg, or you can use a scalp artery like the superficial temporal artery. And they're bypassing the occlusion that they made. And that's unfortunately, that's sometimes the only option. To the right of this is a paper that we published, a tough case that we had of a giant partially thrombosed MCA aneurysm. And here's a picture that I drew. The reviewers asked for a picture. I had not drawn anything to date. And so I apologize. It's not the prettiest, but it kind of showed, again, this isn't really something that you can just put a clip across, when there's vessels coming out of it. And so what we had to do, the red dotted lines show you where we put the clips. So we basically trapped the aneurysm, but we had to use a radial artery graft as a bypass from the neck to an M2, which is the green X that you see. And then actually I had to connect 2 arteries within the brain. So that's the IC. That's an intracranial bypass. Because one of the M2s coming out of the aneurysm, the accessory M2, there was just no way to save that unless you did a bypass. So that's, something that's in the microsurgical armamentarium. And then sometimes, and this is rare, it's not endovascular or microsurgical, it's both. So one of the worst aneurysms that we have in all of neurosurgery is the dolichohepatic vertebrobasilar or basilar trunk aneurysm. These are really challenging. They're not like paraclinoid aneurysms where flow diversion has changed the game. It's not like MCA aneurysms where clipping is just done so well. The natural history of this aneurysm on the far left untreated, it's about a 50% mortality in 2 years. And we have not made progress. It's just, they're so challenging. And I'm treating one right now and they're really hard. So in these cases, sometimes you have to do both. You have to do a bypass and then you have to coil off the aneurysm, but coiling off the aneurysm will sack the blood vessel. So I always think it's important to think about these hybrid approaches where you might need to do endovascular and open. It's rare, probably, I don't know, 1 to 3% of aneurysms in any person's practice. But again, these are my general considerations for treatment. And this is for aneurysms, but really everything. So surgery, I try not to do an open microsurgical case on patients who are 70 or older. That's not to say that I don't. I did a craniotomy for clipping on an aneurysm on a lady who was 80 who did great, and I was very scared about that going into that case. But in general, I think 70 to 80 is a gray zone. But if you're 70 years old, I just think there's a number of medical issues that can have caught up, and so it's a case by case basis. There's not a hard line. It's not to say I have never operated on someone. I mean, I've done burr hole surgeries for a subdural in a 95-year-old. So every case is kind of different. But in general, patients who are 70 or older, I try not to do surgery. If you're less than 70, I think you're a great surgical candidate. Again, that's not 100%. There are 30-year-olds who have prosthetic valves and heart failure that, with an ejection fraction of 20% or something. I mean, that it's not a hard rule. I like surgery for MCA aneurysms. I think it's a surgical disease until proven otherwise. The results are really good. I think it's safe. I liked it also for ACOMs, for anterior cerebral artery aneurysms, and PCOM aneurysms. Those are the main aneurysms that I do surgery for. Small aneurysms, really challenging to wiggle a little microcatheter in to put a coil because you can pop through it, or you push the wire a little bit and it jumps into another vessel, or the coil pops out of the aneurysm and goes down the blood vessel and causes a stroke. So for small aneurysms, I really like surgery. Any complex aneurysm where there's a branch coming out and here and there, and you're worried, well, if I put coils in, is it going to shut that down, or are they going to have a stroke? Anything like that, I favor surgery because you can see it all. It's all in front of you. If something goes down, you can take a clip off. You can maybe do a bypass. And so it gives you more control. And then finally, I think anything that you've tried endovascular that's come back, well, you can try something different endovascular, but there's only so many things you can do. And someone very wise once told me the definition of insanity is repeating the same thing and expecting a different result. And I think with aneurysm treatment, it's absolutely true. If you've coiled something and it comes back, you can recoil it, but I probably wouldn't do that unless you're adding a stent. Well, if you add a stent and you recoil it and it comes back, can you use a flow diverter? If not, you're probably looking at doing surgery, if it's important to really close the aneurysm down. For endovascular, things that I like favoring endovascular treatment would be older age, so 70 years old or older, because it's a shorter case. I do my endovascular treatments usually under a general anesthetic. Some people will do it awake, and that's a big consideration. If it's awake, you don't get a breathing tube. But an endovascular case is anywhere from 15 to 45 minutes for me. So, compared to surgery, the fastest, that a clipping a straightforward MCA aneurysm is still going to be about 3 hours under general anesthesia in my hands. So, hence I like endovascular because it's I think better for more frail patients and easier tolerated. Medical comorbidity, again, we just talked about that. Posterior circulation. So I think we have really good data that endovascular treatment for basilar tip aneurysms, posterior circulation generally is safer than open microsurgical treatment. Why? Well, it's harder to get to, it's deeper, it's close to the brainstem, there's perforators, et cetera, et cetera. That's not true in all cases. So for pica aneurysms, posterior inferior cerebellar artery, I really like open microsurgical treatment because I think endovascular has high rates of recurrence and is a little riskier. Paraclinoid location, so ophthalmic, superior-apophyseal, ventral, or dorsal ICA. I have treated these surgically. It just requires a lot of drilling. You usually have to remove the clinoid process. You have to decompress the optic nerve. You have to lift the optic nerve up a little bit to get a clip around. It takes longer. They're under more general anesthesia. I think if it's huge and it's compressing the optic nerve and you want to decrease mass effect, I think it makes sense. For an asymptomatic, unruptured paraclinoid aneurysm, I think flow diversion works really, really well. And I think that's my first line. Larger giant aneurysms. Again, I like surgery for small aneurysms. Larger giant ones surgically are tough because under the microscope, you can only see so much, as you're looking at a focused field. The aneurysm's 3 centimeters, it's hard to see around it, and there's important blood vessels, cranial nerves. Again, that being said, for this bypass case that I was here that we published, I mean, this was a giant aneurysm, but there was not a good endovascular option. So it's not to say that you shouldn't do surgery on larger giant, but in my practice, if it's unruptured and, they're asymptomatic, my preference is endovascular for large. And then finally, similar to endovascular, if something comes back after surgery, I try not to go back in there. There's a lot of scar tissue, and obviously something with surgery didn't work well. Unless there was some issue and a clip, it was incompletely, treated initially. I generally favor endovascular treatment if it's safe, so if it's the right location for that. This is a breakdown that I did. This is 2 years old. So I've been in practice 4 years in Louisville. This is after 2 years, and it shows you different locations on the bottom, and it shows you my clip versus coil rate, and it breaks it down by whether the aneurysms were ruptured in orange or unruptured in blue. So you can see ACOMs, I'm like close to 50-50. MCAs, I'm much heavier with surgery. Over to basilars, I'm very heavy on endovascular, still coiling most of them. Again, this is old, but I think it gives a nice sense of every surgeon's going to have a different spread of what they like to do based on location. It's very location heavy. Um, Here are a couple examples that I think highlight different treatment strategies. So this was a 72-year-old lady who came in with Hunt-Hess grade 3 subarachnoid hemorrhage. So the Hunt-Hess classification is on the bottom left, and that is how we grade how severe someone's bleed is. So grades 1 and 2, which you can see asymptomatic, minimal headache or a moderate or severe headache, is grades 1 and 2. I'll tell you, I love when people tell me that, I have a lot of residents, we're training people, and oftentimes they'll say a patient's grade 1. Well, I would argue if a patient's asymptomatic or has minimal headache, the odds of them coming to the hospital is very, very low. Coming to the emergency department because your head is killing you. So most patients, I think, are grade 2. Grade 1 is really rare. Grade 3 is when they're drowsy, could be from hydrocephalus, they can be confused. And then grade 4 or 5 is high grade. So these are traditionally patients that we used to think had a really, really poor outcomes unanimously, and that's not true. More recent studies, and we're actually doing a study right now on it. Grade 4 and 5 patients, high grade patients, can still make a really good outcome, and it's about 25 to 30%. So back in the day, I think some people wouldn't even treat patients if they were a grade 5. They'd say, look, they're in a deep coma, like this isn't going to go well. We now know that there is a chance. I would argue for those patients, you should treat them with endovascular because you can really tip them over the edge with a 6-hour, 7-hour operation. But anyway, so this is a lady. Here's her CT scan showing the bleed. Here's her angiogram showing a basilar tip aneurysm. And then to the far right, you see the angiogram of a carotid artery, and it shows an MCA bifurcation aneurysm that was unruptured and was small. So I treated her with coiling. You can use a balloon, you can use Comaneci. You can also put 2 microcatheters in the aneurysm. You can put out one coil, and that can catch the loops of the other coil. So that's called a dual microcatheter technique. And that's a nice technique that you can see here for treating wide neck aneurysms. We've already talked about Comaneci assisting, balloon, and stent assisting. But anyways, what this did was it allowed me to kill the part of the aneurysm that had bled. So if you look at the bottom left, the sideways view of the aneurysm, you see at the top left of the aneurysm, there's a little teat there. There's a little Murphy's teat. That's the rupture point. If you're going to treat this with endovascular and you're not going to get a perfect result, which is very common with just coiling, you at least need to get coils to stop the bleeding, right? So that's what happens. You can see the before and after. We got coils. You can see there's still aneurysm filling at the base. There's still residual neck. But the thought is she's 72. She just had a bleed. Let's get this thing to stop bleeding. Let's get her through the next 3 weeks in the hospital. She might need a shunt for hydrocephalus. We'll bring her back when she's healed up from this bleed, and we will kill this aneurysm with stents and coils. And that's what we did. So here's, a delayed treatment that probably was, I don't know, maybe, a couple months after she came in with the bleed. You can see in purple are the coils. You can see nothing had recurred. This was all residual. It was left residual. And so you can see the before and afters. On the bottom, you see a view from front back, or the AP view. The white line shows you where I was going to put a stent. And sometimes you need 2 stents. In this case, I just needed 1. There you can see the microcatheter putting more coils in. The stent is hard to see. If you look at the third picture on the bottom, you really don't see the stent. What you see are the 3 markers that show the beginning of the stent and the end of the stent. So you can imagine that there's a metal stent, between those 2. And finally, on the AP on the bottom right, you can see there's no longer any residual aneurysm. On the top right is a side or lateral view. You can see, I call it the rump because it's kind of the backside of the aneurysm before, and you can see after it's nicely filled with coils. Um, and then for her unruptured MCA aneurysm, I actually followed it and it grew. And again, if you have a history of a bleed, it can mean that you're at higher risk of an instability. So it grew. She was completely opposed to doing surgery, which I was fine with. She was in her 70s. So I don't generally offer endovascular treatment or recommend it for MCA aneurysms, but I did in this case. And so again, you can see a stent, the three markers of the stent. You can see the before, you can see the coil mass, and she's done great. No recurrences of either, now 2 years out, and doing fantastic. Went back to work as a nurse. This is in contrast, a 34-year-old who came in with worst headache of life and had subarachnoid hemorrhage. And so here's her angiogram, and this is a video. Here you can see the M1, and then you can see it bifurcates into the M2. And she had this little, small bleb of an aneurysm on the M2. So young patient, MCA location, small aneurysm. I think you know where this is going, obviously. I mean, what do these surgeries look like? This is opening the dura, so the frontal lobe is on the right side of your screen, the temporal lobe is on left. You can see everything's red, everything's angry, right? This is an angry brain, it just bled. This is the optic nerve, the nerve that goes to the eyeball. So the first thing with a full swollen brain is you got to open up CSF. So, my left hand is holding a sucker, my right hand is using different instruments to kind of spread and use scissors. So that's the optic nerve. That's the lamina terminalis, which is the anterior wall of the third ventricle. That's the carotid artery, which splits into the ACA and the MCA. So you kind of find the carotid artery and then trace it out. The Sylvian fissure is how the frontal lobe and temporal lobe are kind of connected. You can think about it like saran wrap. You can see it's this thin little tissue. So this is the M1, and again, you have to open this Sylvian fissure. You have to be delicate. You can't go through the brain. And this is kind of, again, opening, and eventually we'll kind of get close to the aneurysm. And so this is the M1. Here's the anatomy labeled. So you can see the MCA vessel, the M1 is the first part, and it splits into an M2. There's a superior division, inferior division, and then it's off of the inferior division of the M2 that you see the aneurysm. And it's hard to see there, but it's coming into view, which means I need to get ready for it to potentially repop on me, right? So to prevent that, I put a clip, and this is only going on for about a minute or two. So you put a clip on, and that means, okay, flow's not going in the vessel now. So if it pops, it won't bleed that badly. That lets me get more aggressive with opening things up, finding the aneurysm, and defining it. So, and it's kind of in a weird location. It's on the back wall. So I have to use a clip that's actually shaped with a 90-degree bend and that has a hole in it. So the hole is going to allow the M2 to go through it. And the 90 degree is what allows me to reconstruct it. So, and again, when I first put it on, it crimped the blood vessel a little bit. So I adjusted it and everything looks great. And here's the ICG, which is a fluorescent dye we use that shows everything's filling well. Here's the angiogram with three-dimensional reconstruction. It shows you the position of the clip. Again, that's a fenestrated 90-degree clip. So fenestrated meaning it has a hole in it, which allows a blood vessel to go through it. And 90-degree meaning it's at an angle because it was kind of on the back wall of the. So even with clipping, if the aneurysm is not right in front of you, you can still get a nice result. And so that's clipping. Think I'll skip this one in the interest of time, but this was a ruptured ACOM aneurysm, and he had an MCA, really challenging case. Again, this was someone before me who treated it. He coiled it, it came back. He recoiled it, it came back. He put a stent and coiled it, and then he came to me in his 70s. I think he was 73. And I said, I think we're looking at surgery. So I really don't want to do surgery. I said, there's only one move that I have. I can put a stent in the one vessel that doesn't have a stent, and I can put more coils in it. And I did, and I cured it. It looked amazing. Here's the red arrow. But this guy continued to smoke a lot. And unfortunately, it came back, within about 6 months. So eventually I had to do surgery. So this is surgery. You see all the coils being cut out. You can see the stent in the bottom right picture, within the blood vessel. So really cool to see those devices. Sometimes we coil it to get them through the bleed. This is a patient we did a bypass for. And this is that web. That's a web in an MCA that I took care of a couple of weeks ago. Here are the clips going on. You have to kind of mash the device up. So in conclusion, the natural history of unruptured aneurysms depends on location, size, and various risk factors. We've talked about ISUIA and UCAS, which really give you a specific percent risk of rupture. And then we've talked about phases and elapse, which also give you an estimated risk of rupture. UIATS is a great treatment score or guidance system, and I think people should use, all of them. Natural history is limited. It's not the same as presentation data. Again, so if you know someone who presented with a ruptured aneurysm and it was in this location, that doesn't mean that that location automatically has a very high risk of rupture. It's just, you know, it's not the same as natural history. I like to treat aneurysms that are 5 millimeters for the most part based on UCAS. And if it's a high risk location like ACOM, PCOM, or an ugly basilar tip, or there's family history, or they have a prior bleed, I will consider offering treatment for a 3 or 4 millimeter aneurysm. I don't treat aneurysms generally that are 1 or 2 millimeters if they're unruptured. You need to know life expectancy to decide whether to treat the risk of doing something. So again, we've talked a lot about risk of rupture. What's the risk if we do treatment? It's usually 5 to 7%, but that varies on patient. It depends on what they're doing, the surgeon's doing, and it depends on a lot of things. What is the lifetime risk of rupture compared to the risk of treatment? That is the end of the day what you need to ask. Each patient requires an individualized treatment plan. Treat the patient, not the aneurysm, I say. Microsurgical clipping remains an excellent option, especially for anterior circulation aneurysms. I like it for those locations. And then retreatment can sometimes require conversion, from endo to open. With that, I want to thank everyone. Here's my social media. Thanks so much, Christine, for having me on this. It's been such a privilege to get to know the Brain Aneurysm Foundation. We're hosting a 5K in October. Please put it on your calendar. Come out to Louisville, visit us. We'd love to have you. It's bourbon country, for those of you that like bourbon. And I'll take any questions.
Yeah, thank you so much, Dr. Abecassis. That was, I mean, honestly, that was a wonderful presentation. And I think you addressed most of the questions that I had submitted, but there was a couple things one thing I did want to ask about the studies, ISHUA, the UCAS. I mean, one was done in the 90s. UCAS looked like 2004. What about the UIATS? When was that completed?
So the UIATS, I'll have to pull up the publication. I want to say that it's in 2010, 2012-ish, I'm guessing.
Okay.
It's not and I don't know if I have the year on here,
So
unfortunately.
my question, I guess, is like, are there studies like this that are going to occur again? And the main reason I ask is we're going to Capitol Hill May 7th, and every little bit of data we provide needs a reference, and it's
Yeah.
kind of like it's so hard, like when we're fighting to get more money for research and who this impacts, and our data references are so old. So do you see any new, like reviving any of these studies and bringing them into the modern day, or do you think it would change much or not?
I think it would be very useful to have. I think in the United States, medicine is practiced very different than the rest of the world. We tend to practice medicine very defensively, meaning that if someone walks into your office with a 5 millimeter aneurysm, we rarely, and they have a family history or they have headaches and they kind of want it treated, we rarely, the question is, would people in the United States say, you know what, you're a great patient to put in a study? That means, I'm not going to know which, you're going to go in and we're going to follow you until, if it ruptures. And if it doesn't, most patients say no to that. They want to, in the US. I do think some countries that are less aggressive about aneurysm treatment, and that's like, and really good at following patients, potentially might be able to contribute more studies and literature. But I think in the US, I think number one, providers practice medicine a certain way. Number two, patients tend to have that expectation. A lot of patients, when they have that, they want it treated. It's more often that I have to tell a patient, like, look, I don't think this has that bad of a natural history. I really think we should watch this. I have to talk them into that more often than telling them that we should treat this. They usually come in predisposed at wanting treatment. That's okay, but the question is, will those patients go on to sign up for a natural history study? I think that's going to limit our ability in the U.S. at least to get studies and data like that. But it's super important information.
Yeah, no, that's great. And one other thing, there is a lot of like that mental health component to someone who has an unruptured, and particularly when they are told to wait. And someone did ask the question. She lost her son 3 years ago and apparently has like the same type aneurysms, and the doctor's telling her to wait. So I think that's super hard. So I don't know the size of it, but presuming it's like it's that the three size. I mean, would you take into consideration that person's sort of fear, anxiety, and everything else, particularly if they're younger than 70, to decide then to treat it?
Absolutely. And I think that's done in UIATS. They give points for reduced quality of life due to fear of rupture. That's a real, and I really like that they include that in that. I totally do. Like I said, 5 is usually my threshold. 3 to 4, I always entertain for being a really high risk location, any bad risk factors, any sort of anxiety, stuff like that. I think the other thing I'll say is I don't think people get multiple opinions enough in medicine. I tell that to all my friends. You'll go get 5 opinions or 3 opinions to fix your car or fix your roof. Get multiple opinions. Ask providers. I tell patients all the time, please go get another opinion. Not that I don't want to treat you. I obviously want to treat you or I want to
Yeah.
follow you, but I want you to feel really good about this decision. And it's not to say that you need to get another opinion because the first opinion isn't good. The more opinions you get, the more you're educating yourself about this. So you can do it locally. There's usually 3 centers that, even within the same center. I mean, I always offer,
Yeah.
I have a partner at U of L that does aneurysms. There are 2 other shops in town that do aneurysms. I can give you some names for people that are in Cincy or Vandy, something close
Yeah.
by, not too far. I can give you national names if you have family in Boston. I mean, you tell me, but let's get as many opinions. I want you as educated about this as possible and feeling good about whatever decision we make, whether it's follow it, treat it with endovascular, or treat it with open.
Yeah, no, I love that. And that kind of goes along with what you said about treating the patient versus the aneurysm. So I agree with second opinions. I mean, we sometimes have people call, someone said clip, someone said coil. I'm like, go see someone else and, be comfortable with whoever you end up deciding, but get someone and see where that third person is going to, lead you. So there's one last question here I just want to address, and then we'll wrap things up just due to time. And I appreciate you staying on, but someone had was diagnosed with a 5 by 5 by 7 basilar aneurysm, scheduled surgery 10 days later, and she ruptured 2 hours after her consult. So generally, and I have heard of that before, it's
Yeah,
certainly
me too.
definitely rare, but how often when someone does come in, what's generally the wait time for surgery?
Yeah, it's a tough question. I mean, I think most people, when they come into the office and they have a new aneurysm and you say that it needs to be treated, they're like, let's get this over with. Like, I want this treated immediately. Obviously, again, I think you got to lean on the natural history study. So if we look at UCAS and you say, what is the annual risk of rupture of a set, I use the bigger of the number. So, a 7 millimeter basilar tip aneurysm, you're talking 0.97% per year, so 1% per year. So I always tell patients, could this bleed tomorrow? It could. Even if your risk of rupture is 0.005, what are the odds? Well, 1% divided by 365 is low. I think it's bad luck. I mean, I can't say if a patient starts, there are a couple warning signs. So if a patient starts getting sentinel bleeds, meaning, I get headaches and I got this diagnosed, something's different. Like I don't know if it's the weather, but the headache feels different. I'll try to get that. If they come into the ER with that, I'll try to treat them like not, in 12 hours, but I'll be like, okay, let's get this taken care of before you leave. I think that's rare. And sometimes it's anxiety. Sometimes headaches are tough. Do headaches get better with aneurysm treatment? That's a whole nother, you could do an hour on that. There's a lot of stuff looking at that. In general, I try to get treatment within a month, I would say. And that's not by choice. That's just how backed up we are. I mean, obviously, we need anesthesia, we need block time. Sometimes we get it done a little sooner than that, but I usually tell patients do this within 3 months. If you've got a 1%, let's say it's a high risk aneurysm, you got a 1% or 4% risk of rupture. If you wait 3 months, you're looking at less than 1% of it bleeding. So I think that 3 months in general for an unruptured aneurysm that does not have a change in symptoms or sentinel headaches is a reasonable amount of time to wait.
Awesome. Again, I just want to say thank you so much for taking the time. This was just an amazing presentation. I see the comments. It's one of the better ones I've seen. It flew by too, and I just think you answered any questions that had come up prior. So thank you so much, Doctor, for this. Everyone knows this is recorded. It will be shared, but I just want to say thank you and look forward to seeing you in Louisville for the
Yeah,
walk. That's
Christine,
first
thank you.
annual.
Thank you. And thanks everyone for coming. I really appreciate your time. And it was a privilege. I hope to come back.